Good evening, everyone. Hi, my name is Rachel Cleet. I'm a professor of City and Regional Planning and the section head for City and Regional Planning here at the Knowlton School of Architecture. And it's my pleasure tonight to introduce to you Dr. Megan Sandel. So one of the things I find interesting, planning is an interdisciplinary field, and more and more lately, in the past few years, planning has been much more becoming more concerned with what it means to be healthy in the urban environment, and how the work that we do as planners interacts with the work that folks in public health do and the medical community do. So Dr. Sandel is here in that spirit to help us understand more about those connections between the built environment, urban environments, and health and healthy living. So Dr. Sandel is an associate professor of pediatrics at Boston University Schools of Medicine and Public Health. She's also the medical director of the National Center for Medical Legal Partnership and a co-principal investigator with Children's Health Watch. She's also the former pediatric medical director of Boston Healthcare for the Homeless program and is a nationally recognized expert on housing and child health. In 1998, she published with other doctors at Boston Medical Center the Doc for Kids report, which was a national report on how housing affected child health, and it was the first of its kind. Over the course of her career, Dr. Sandel has written numerous peer-reviewed scientific articles and papers on the relationship between housing and child health. She's also served as a principal investigator for numerous National Institutes of Health, Department of Housing and Urban Development, and foundation grants. She's also working with she's worked with the Boston Public Health Commission and the Massachusetts Department of Public Health to improve the health of vulnerable children, particularly children with asthma. She served on numerous committees and advisory boards, such as the National Center for Healthy Housing, which is a national advocacy group, both the National American Academy of Pediatrics and the Massachusetts Chapter's Committee on Environmental Health, and the Center for Disease Control's Advisory Committee for Childhood Lead Poisoning and Prevention. Interestingly, Dr. Megan Sandel is the first physician to join the board of Enterprise Community Partners, which is what we call a housing intermediary. It's a national organization that seeks to finance and provide technical assistance to local governments and local nonprofits to build affordable housing. So here we really do see where these two worlds are really intersecting. And so I give you Dr. Sandel.
Thank you very much. Can you hear me in the back? Yeah? All right, good. Awesome. So I will say, I have a medical degree and I have a master's of public health. I have longed to get a master's of urban planning or architecture degree, and my husband says no more degrees. So I'm really excited to be here speaking to you today to kind of learn from you and to really kind of start a conversation thinking about housing and health more interrelated. I titled this talk, The Housing Vaccine, Why Stable, Decent, Affordable Homes Keep Communities Healthy. And I'm hoping I'll talk for about 45 minutes and then open it up for questions. So first I want to just talk about kind of how does housing influence health? How has our understanding of how housing influence health changed over the last, say, 10 to 20 years? I will say this concept of housing and health being related goes back probably 2 centuries, right? I could show you from 1911 the public health report that's called Housing and Health. But I think that what's interesting is if you read that article, they're talking about tuberculosis and they're talking about cholera, and they're talking about fire hazards, right? And so when you think about it today, we may talk about pests, and we may talk about affordable housing, and we may talk about mobility in ways that weren't necessarily in that first. So I don't think it's that housing and health is a new concept. I just think what it means has definitely changed. I'm going to talk a little bit about why I've sometimes thought about housing as being like a vaccine, and talk about how we think about vaccines as having multiple but sometimes differential benefits, and really talking about how we view vaccines as being both beneficial to the individuals that get vaccinated, but also to society on a whole, and how we can think about housing in that way. I want to talk a little bit about the linkage between housing and neighborhood, and particularly talking about housing as the first in a series of interventions in order to address the social determinants of health, and how really when we're talking about neighborhood, we're talking about people and we are talking about place. And then I want to talk a little bit about opportunity, citing some of the great work that's here at Ohio State at the Kirwan Institute, among others, and really talking about equitable opportunity and some of the really interesting broad partnerships that are starting to be formed both between Ohio State University and many community partners, including the City of Columbus and redeveloping Weinland Park, and then also Nationwide Children's Hospital. So I have an ambitious 45 minutes. Fasten your seatbelts. Here we go. So I think that one of the interesting things around housing and health is that there's really good evidence around housing quality and health implications. I think there's decades of research around how the development and worsening of asthma is tied to very specific housing conditions. Things like pests such as cockroaches or mice in the home, molds or chronic dampness, or thinking about tobacco smoke, particularly in the housing setting. There's really important research around lead exposure tied to housing, and the CDC recently lowered the level of lead to an action level of 5 micrograms per deciliter. And so our understanding of the depth of which how lead affects health is really important. And then I also think sometimes when we think about housing quality, we sometimes need to think about energy, right? That oftentimes families may be making a heat or eat trade-off that can happen, and how that housing costs and energy costs can lead to poor health. But one of the things that's newer is this research that was out of Boston College and was featured in a really nice set of briefs. So those that are not medical people, I'm going to talk a little bit about the medical literature, but the MacArthur Foundation has invested in a bunch of these briefs that are called How Housing Matters. And for those that are interested, I really encourage you to get on the MacArthur website where they feature these. And this is about how housing quality is tied to actual socio-emotional behavioral problems. So it's easy for you to think like, okay, so you're having trouble breathing because you have mold in your house, but that mold in your house may also mean you do more poorly in school, and that you may actually have more mental health problems as well. And so that when we think about housing, I think that it's important to realize all the different aspects that it can matter. I work at a children's research and policy network called Children's Health Watch, which is based in Boston, but collects data in 5 different cities. And we've been lucky enough to get some MacArthur research funding in order to look more in depth at housing and health issues. We focus predominantly on how different types of hardships, whether it be hunger, unstable housing, problems keeping the heat or the lights on, affect the health and development of young children. And then we try and use our data to improve the policies that are addressing those hardships. And we really try and focus particularly on providing policymakers with the evidence in order to develop policies to protect young children's health and development. And so our data comes from the healthcare setting. So we collect data in 5 cities, in Boston, Baltimore, Philadelphia, Little Rock, and Minneapolis, in predominantly emergency departments or primary care clinics. And we focus on a really critical population, which is kids 0 to 4 years old. And we focus on that subset because it's a really critical window of development. This is when you're growing the brain you're going to need for the rest of your life. And this is typically an invisible population. It's a population that typically is not in school yet, and oftentimes they're in this critical window. They're very vulnerable. They're almost my mentor and the founder of Children's Health Watch, Dr. Deborah A. Frank, talks about them as the canaries in the coal mine. They're very vulnerable to public policy changes, and yet they oftentimes aren't on people's radars because they're not in school. And so this is some research that we published based off of some of our MacArthur grants, which was at the American Journal of Public Health, looking at what was the connection between housing insecurity and health in very young children. And I'm going to show you kind of the critical table when we think about the connections between unstable housing and hunger. So if you look up here, and I realize it's still, even though I'm blowing it up, maybe hard, when you look at the household and food insecurity, people that are overcrowded, which is a more moderate form of housing insecurity, you see higher rates of food insecurity, statistically significant. You see essentially more equivalent rates of fair or poor health or developmental risk. But it's when you start looking at the people who are moving 2 or more times in a year, that level of severe housing insecurity, and you see just astronomical rates of food insecurity and fare for health, almost twofold across the board. And so when we start thinking about it, I want you to think about, we tend to think about homelessness at one continuum, and we think about stable housing on the other, and we don't acknowledge that there's a lot in between. And so that housing insecurity is this idea that oftentimes families that may be moving 2 or more times in a year look as bad as homeless families in terms of developmental risk and in terms of hospitalizations. And so we need to think about it not just as an either or, you're either homeless or you're not homeless, but really that housing insecurity is an important part of that continuum. We also have recently started thinking about housing insecurity also as being behind on rent. And we have started looking at this issue of the hidden homeless, people that may be moving frequently or overcrowded, or maybe a paycheck away from homelessness, right? That instability and the fact that they're having to clearly make trade-offs between rent and maybe healthcare or food or heat. And so we've shown that they have much higher rates of child food insecurity. So this is important. Food insecurity is that you have the unstable amounts of food, kind of inconsistent amount of foods. But child food insecurity means you're reporting cutting back on the size of the meals for your kids, right? So it's a very extreme form of child food insecurity that we see high rates of child and mothers reporting fare or poor health, more likely developmental delays, and mothers being more likely to be depressed, related to this idea of being behind on rent. And what is important to keep in mind is 1 out of 4 renters in Ohio are behind on rent, right? Severely housing burdened, paying more than 50% of their take-home income on housing. And so this is some nice reports that are developed by the Kirwan Institute in conjunction with, and it's hard to read this logo down here, but it's for the Community Development for All People, a local community development corporation that works predominantly in the south side of Columbus. But when you think about housing stressed families, ones that are behind on rent and having difficulties, they may be spending 30% less on food, or they may be spending 50% less on clothing and 70% less on health care. And we think about how that residential instability results in things like changing schools, starting in one school district and finishing the school district in another, and thinking about ways in which that can undermine child development initiatives. And I think that what's important to keep in mind is that when we talk about this housing instability, over half of the families that we see in the 5 cities where we collect data have some form of housing instability. They may be homeless, they may have frequent moves, they may be behind on rent, or they're overcrowded, but over 57% are going to have some form. This is the Philadelphia brief. We also have other briefs from the other 5 cities. And I'm going to tell you that Columbus is not that different. That if we were to collect data, this is the picture that you would see, that housing instability is incredibly common. So I'm hoping that I've convinced you that housing matters, right? Housing matters from kind of decency, right? Housing quality matters, that housing affordability matters, that housing stability matters. And so then let's talk about what are we going to do about that? How could housing be like a vaccine against those problems? And so just for those particularly in a non-medical audience, right, what are the properties of why we like vaccines? Why do we support vaccines? Well, we support them because they provide benefits against multiple threats. They often can build immunity that's perceived to be long-lasting. It helps you now and in the future. And I think that's important to realize that we acknowledge in the vaccine world that it doesn't get treated equally to everyone, right? And that there's a differential benefit. We're okay with the fact that certain people will benefit more, or you may target a vaccine towards a certain high-risk group first because you want to see that benefit. And so we acknowledge that it's not one size fits all always for vaccines. Sometimes it is, but sometimes it's not. And then I also want to kind of talk through a little bit about when we think about vaccines, why do we think about them as benefiting both individuals and society? What are the different ways in which we think about that? And that I'm going to then kind of shift gears to talk about if housing is a vaccine, how is it a vaccine in the first in a series? How does having the housing vaccine first make it more possible to have positive benefits in, say, healthcare or in education or in other areas? So this is a publication that we published about 10 years ago in the Archives of Disease of Childhood, where we looked at this idea of what does a housing subsidy mean to families. And so we compared families that were on the housing waiting lists and food insecure with those that were receiving some form of housing subsidy and food insecure. Because we were interested in this kind of high-risk group. You're already food insecure. What did it mean to have a housing subsidy? And I think it's important to keep in mind, if you're on a waiting list, it means you're eligible for housing. And oftentimes, many times, those waiting lists, families can wait 5, 6, 7, 8, 9 years. And so we looked at it, and what we showed was the families on the waiting list were twofold more likely to have stunted growth related to their food insecurity than the families that were receiving the subsidy, right? So the subsidy protected the food insecure families from not having that food insecurity play out on the bodies of their children, right? So that's the multiple benefit idea, that you're seeing this benefit related to housing having impact in multiple areas. I want to talk about one of the more controversial areas in which we think about housing and vaccines is thinking about an experiment called moving to opportunity. And I think that what's interesting is that the federal government was really interested in understanding housing subsidies and how this played out. And so they embarked on a randomized controlled trial. And so those in the non-medical world, we like randomized controlled trials because they essentially try and isolate an intervention as being the only thing that's different between groups. Because you get everyone in a group, you flip a coin about which group they're assigned to, and then you follow them forward. And that's one way in which we control for different types of things that may influence the outcome. And so this was a study that was done in 5 cities: Boston, Baltimore, Chicago, Los Angeles, and New York. And it was really designed to look at how relocation influenced things like employment, income, education, and well-being. And so they took 5,000 families in these 5 cities that were living in typically public housing in distressed neighborhoods, and they randomized them to one of 3 groups. They randomized them to have a low poverty voucher that could only be used in neighborhoods that had less concentrated poverty. So that was the group that was going to get kind of theoretically, that was the one that was hypothesized to have the best outcomes. They randomized some to be in a traditional voucher group. They said, here's a voucher. You can rent an apartment somewhere else and have your rent protected so you're not spending a lot of your income. But typically a lot of the families, without counseling and without help, typically rented in very similar neighborhoods to the ones that they were actually living in at the time. And then a third of them were randomized to remain in the public housing in the distressed neighborhoods. And what's interesting is they've continued to study these families in kind of 2 different waves. And so what's interesting is I'm going to present 2 of the kind of the biggest, kind of studies from it, and just talk a little bit about the glass is half full and the glass is half empty when thinking about this. So the first is a publication from the New England Journal of Medicine. Jens Ludwig published this in 2011, which was looking at how did this randomized experiment influence obesity and diabetes in the mothers, because these were predominantly female-headed households, in the mothers of these families. And what's interesting is that they showed an enormous change in the body mass index. So this is the severe morbid obesity. They reduced it by 3 or 4 points between the low poverty and the control group. You saw actually larger changes actually between if the BMI was higher. And then they also looked at your diabetes rates. That was a hemoglobin A1C is the name of the blood test. And they showed, again, kind of a 4-point difference between them. And so on the one hand, you may say, what's the big deal, right? Like they only moved it by 3 or 4 percentage points, right? But what I'll tell you is that if that was a drug that moved a overall 15 to 20% reduction in the overall rate, it would be on the pharmacy of every healthcare institution in the country, right? This is what we use as a benchmark for success. And here was a housing intervention that had a very similar effect on health. Then that was totally not designed to have that effect, right? So the other study that is kind of the glass is half empty is Ron Kessler published this in JAMA, the Journal of the American Medical Association, looking at the association of the housing mobility interventions on children, boys and girls, and subsequent diagnosis of mental health disorders. And in this, it was interesting looking 10 to 15 years after these families were moved. And it's interesting that the boys in the low poverty voucher group had higher rates of mental disorders than the control group, right? somewhat even twofold differences between them. The girls in the traditional voucher group actually had lower rates compared to the control group. And what's interesting is that it's hard to, these are very small numbers actually when they're looking at them. You know, these are 40 boys or 50 or 60 boys, but they're still statistically significantly different. And it's also interesting that these are typically mental health disorders as diagnosed by a questionnaire, which is a validated questionnaire, but is not diagnosed by a mental health professional. But still, this is concerning, right? What did this mean for these families to move from more concentrated poverty neighborhoods, often very segregated neighborhoods, into less segregated neighborhoods where perhaps the boys were treated differently, perhaps the boys had an unintended consequence related to this. And if you listen to the podcast that Ron Kessler did in conjunction with this article, he doesn't suggest don't do mobility. He actually just talks about the fact that we may need to think about how doing mobility differently. But it does make you start to think about what's the linkage between housing and neighborhood. How do we think about ways in which to provide the housing vaccine to avoid unintended consequences? So why do we vaccinate in general? Why do we think about it as both an individual and a societal benefit? So this is from the British Medical Journal, where it talked about vaccinating healthcare staff and looking at the rates of morbidity and mortality in high-risk elders. And what's interesting is you would think, right, I as a doctor need to get my flu shot each year, and you would think they do that so that I show up to work, right? I don't get the flu. But it actually has more to do with the fact that I don't give the flu to my patients, right? That the transfer is that it not only matters to me as the individual, but it matters to the people that I treat. It's like when we vaccinate elementary schools very well, typically that decreases the rate of flu in elders in the community because typically grandparents are not getting the flu from their grandchildren, right? So we see that type of benefit often. And what's interesting is that when we think about something like chickenpox vaccine, so I wasn't vaccinated against chickenpox, but my 3 kids all were. And so why do we do the chickenpox vaccine? And so they actually did a cost effectiveness analysis for it, published in JAMA. And what's interesting and important to note is that when you look at the actual routine chickenpox vaccination and how it reduces healthcare costs, it actually doesn't save money, right? For every $2 you spend on the vaccine, you only save $1 in healthcare costs. But when you add in the lost work days of the parents having to stay home with their kids who have chickenpox, that flips, so that for every $1 spent on that vaccine, you get a $5 societal benefit. So we vaccinate kids against chickenpox, not necessarily to save money on healthcare, but to make sure that people stay in work, right? And so we already have made that societal decision that this is why we require chickenpox vaccine, right? It doesn't necessarily mean that to the individual benefit, it's all about the societal benefit. And so when I start thinking about kind of the housing vaccine, what does it mean? I often like to talk about how housing ends up as the foundation to other interventions, right? That when we think about it, it's not to say that housing, you know, once you solve housing, you're done. All the social determinants of health go away. It's really about thinking about housing as the first step, as the important foundation that you need to lay. And so in this, it was a randomized trial that they did in homeless adults in Chicago, where they randomized them to intensive case management or to intensive case management and an apartment, an actual housing subsidy. And what they basically showed was that usual case management was pretty ineffective in terms of preventing people coming into the emergency room or hospital related to their chronic disease. So it was really about the housing that made that medical intervention better. You know, what I tend to say is that you can have the most high-tech, beautiful HIV medicine, but I'll tell you it doesn't work very well if you don't have a house to remember to take it. And so when we think about healthcare costs and other things, particularly in chronically ill populations like the homeless, this is where aligning housing and case management together, oftentimes you can save money. In Denver, they saved $15,000 per person when they aligned their human services, healthcare services, and housing services together. The other thing that I think is important is thinking about housing and education. I was asked to write a blog about urban education. I'm not sure how they found me, but I said, I'm going to tell you what the secret to urban education is, and it's affordable housing. Because what you tend to find is that in a lot of places, a third of kids in a given school may churn, may start the school year in one school and then finish the school year in another school. And a lot of that is related to housing insecurity, the fact that they may be homeless, the fact that they may be moving frequently, the fact that they may be overcrowded. And so when we think about those issues, adding on to that then chronic absenteeism, that a lot of these schools may have 50% of the kids that don't come at least 10% of the time, right? Let me flip that around. Chronic absenteeism is that you miss at least 10% of school. So you can imagine you're trying to do this really great educational intervention, and what happens? You essentially end up with an issue where you don't have kids showing up regularly, or they don't stay long enough in the school to actually see the benefit. And so when you think about it, it starts with housing, and then you can build out to the school intervention. The other thing to keep in mind is just the costs attached to non-investing in housing and how those play out in the educational system. This is a really nice brief out of the Center for Housing Policy, Should I Stay or Should I Go? And it basically showed that a study in Minnesota showed that if kids moved 3 times between 1st and 6th grade, they scored on average 20 points lower on their reading scores than similar students who had not moved. And so when you think about kind of race to the top and performance metrics for schools, it's being able to track the churn rate and how often people move so that you can try and address it is going to be one solution. But the bigger deal is, can we just make sure the communities are more stable so that you don't have to worry about this detriment? One of the cool things about coming to Columbus is getting to meet people who are doing really innovative work. And so one thing that you may or may not be aware of is the Kirwan Institute here at Ohio State has developed an opportunity index for neighborhoods to really try and quantify what does this mean. It pulls an array of indicators together really to demonstrate how these different factors are going to impact an individual's or family's chance of success. And I think that what's really interesting to me is it's both community level, individual, and family needs that are integrated into a really nice set of factors. So this is the 19 different factors. Again, I don't expect you to look at all of them, but it's nice that they've grouped them into kind of 3 different categories: educational opportunity factors, health and environmental opportunity factors, and then social and economic opportunity factors. And these are all data that are publicly available, so that another website that's really interesting is called diversitydatakids.org. And so any of the census tracts, any of the 100 metropolitan areas across the country, you can dig up the maps because they have been able to find all of this data. And so what they've ended up doing is taking these factors and coming up with the different scores so that you end up with very low opportunity being as yellow up to very high opportunity being these red. And you're able to kind of amalgamate all these different factors together. And so when you look at it, you end up with a map of what Columbus looks like, right? So you end up looking at, here's kind of the south side and different areas around, I think Weinland Park is over here, so that there are these areas where you see these low opportunity and then high opportunity. This is really about how we think about opportunity operationalizing itself, because these are where people are living. And so when we think about what that means is, you may have a lot of need for early education centers, and yet if you were to map where the early education centers are, they typically are going to be in this part of Columbus, not necessarily this part. One of the things that I think is really important is when we think about opportunity, we often think about it as something that's in isolation, and I think we have to really acknowledge that there's an enormous history of redlining and segregation that really limits the number of opportunities. And so I really like when we think about what neighborhood segregation plays out and the impacts on health or school segregation, educational achievement, exposure to crime, or other things. I really like this Malcolm Gladwell quote, which kind of talks about why opportunity matters, why it can make a difference. And so biologists often talk about the ecology of an organism. The tallest oak in the forest is tallest not because it grew from the hardiest acorn. It's tallest also because no other trees blocked its sunlight. The soil around it was deep and rich. No rabbit chewed through its bark as a sapling, and no lumberjack cut it down before it matured. We all know that successful people come from hardy seeds, but we do know enough about this. But do we know enough about the sunlight that warmed them, the soil which they put the roots down, and the rabbits and lumberjacks that they were lucky enough to avoid? So it questions a bit this idea of like, pull yourself up by your bootstraps. Good luck, because if you're in a different neighborhood where you don't get sunlight and you have to watch out for lumberjacks and rabbits, you may not grow to be the tallest tree. And so just to follow that analogy, I'm going to talk a little bit about equity of opportunity. And when we think about equity, I think it's really important to talk about the difference between equity and equality, right? So when we think about what equality is treating everyone the same. But what happens is that we know that people start from different heights, right? We know that they start from different neighborhoods that are going to give them those opportunities to reach that apple that's going to be health, right? And so that when we think about it, it's oftentimes that the only way that you get to have each equal chance to get to that apple is that you have to actually treat the neighborhoods differently. You have to invest more in the lower opportunity neighborhoods in order to make it more possible for everybody to reach. And so I think sometimes people use equality and equity interchangeably. They are very different concepts. And I think that it's really important when we start thinking about where we place housing, how we think about housing, how we think about the expectations of people who live in neighborhoods, that we really think about an equity lens more than a quality lens. This is just one other kind of aspect I think to think about. This is a needs assessment that the Kirwan Institute put together, thinking about asset building. I think we often will talk about neighborhoods and we map them based on detriments, right? The infant mortality maps, the diabetes maps, the hypertension maps, things that are negative, when I think that oftentimes we really have to talk about what are the assets in a neighborhood of which you can build and increase opportunities. So that oftentimes I will say that people and place are interchangeably linked. And so we have to really be thoughtful that when we're doing, say, design of affordable housing, being able to do design charrettes with affordable housing groups and with the community so that you are able to think about ways in which to bring the affordable housing and have their community engagement matters. I will say a lot of these neighborhoods have been systematically disinvested in for generations. And so the idea of community engagement is really great. They may not be ready for community engagement all the time. And so one of the things that I've really appreciated learning about Columbus is the opportunities to United Way, Kirwan Institute, and Nationwide Children's Hospital, for instance, doing neighborhood leadership academies, being able to engage with communities so that they can be able to have a voice and say what they want and really acknowledge that power dynamic so that you can have true lasting change. One of the really amazing kind of developments has been linking Ohio State with its neighborhood to its eastern side, which is Weinland Park. And I think, like most urban neighborhoods, Weinland Park has lost jobs and population over the last 40 years, and it's historically struggled with poor maintenance and high crime and other things, and that they have a green space in the center of it. And so really trying to double down and think about it. How are the ways in which we can redevelop this neighborhood in order to improve the health? What's the way in which we change the map from bright yellow to bright red and thinking about it? And so it's really been a campus partnership, right? Thinking about the campus partners for community urban development. And so it starts with Ohio State University in cooperation with the city of Columbus and being able to create this kind of active partnership for the community urban redevelopment and really kind of spearhead the revitalization of the university district. And over the last 10 years, they've been actively thinking about ways in which to target this particular neighborhood. I think its real goal is to preserve and improve low-income housing and then really promoting the economic diversity and integration and neighborhood stability in Weinland Park. And so there's really this kind of new era because when you think about it, we talk about kind of housing vaccine as one of the first of a series. It's investing not only in housing, but it's investing in a new school, right? It's investing in different corporations where you can bring affordable housing. It's thinking about ways in which you're going to be able to preserve existing housing, do new construction, and be able to bring in both market rate housing with affordable housing, and being able to have that mixed income and that integration can be really, really powerful. I think that the neighborhood plan has been a real, so that it's a very intentional process has been really important, and thinking about ways in which you can bring in a lot of different support. And there's a whole long list of partners I'll show in a minute. But I sometimes will think, we typically have thought, oh, I build an affordable housing unit in a neighborhood that's distressed, and I'll expect it to revitalize alone. And I say that that often is like giving one shot in a series of vaccines and expecting you to build immunity, or giving one course of chemotherapy and not completing the 10 courses in order to cure the cancer. It really is, community development is about dose mattering, and you have to really, I think the Weinland Park is a really nice example of applying a really concentrated dose to try and improve a neighborhood. This has been acknowledged nationally. So in 2015, the Housing Visionary Award at the National Housing Conference acknowledged the Community Properties Initiative, and really thinking about ways in which they've been able to leverage public and private investment in order to help this inner city Columbus neighborhood. And I think that it's really becoming a really great example that's being a roadmap for other places across the country. There are things like the rehab units, different types of units that have been demolished and then rebuilt, and then also sold at market rate, again, to bring in different types of families to the neighborhood so that it's a mixed. And then when we think about it, there are new ways in which they've been able to get other grants around different types of choice neighborhoods, which is a federal funding stream that allows them to do really interesting implementation. So this is thinking about the Columbus Metropolitan Housing Authority, McCormick Barron Salazar, the City of Columbus, and others that really talk about ways. And then what I think is really nice is that they've thought about all the different ways to address it, being healthcare, wellness, behavioral care, education, job training, kindergarten, and thinking about the intensive case management that's going to make it successful for families and for seniors. And so being able to think about that combination set of vaccines where you start with housing, but you're bringing in all the other things to address the social determinants of health. The other kind of really cool Columbus example is in addressing the equity and opportunity gap is from Nationwide Children's Hospital. They've created a Healthy Neighborhoods, Healthy Families program, and they really have thought about it as a pronged approach. They start with affordable housing as that first vaccine in the series, but thinking about safe, accessible neighborhoods, bringing in neighborhood watches, really building on education, investing in the local public schools, health and wellness, being able to build a local farmers market that has free food available to it, and then doing very targeted workforce development. And so when you look at some of the beautiful, old dilapidated housing that they have now taken over and rehabbed and now sold, they actually have focused on some of their employees. So they have a neighbor and a colleague, people where they've taken their employees and sold homes because they want to try and rebuild the neighborhoods together. And then really have done some amazing work around workforce development. Nationwide Children's Hospital has hired more than 250 Southside residents, and they have over 500 employed. They're really focusing on ways in which they can partner with Columbus State Community College to do kind of fast path getting people into their jobs and being able to work up through it. So really kind of nice examples of not just doing housing, but thinking about all the social determinants of health together. And so just in closing, and I'd love to have you guys start thinking about some questions, is I hope I've convinced you that housing does influence health and that housing can act like a vaccine. And we acknowledge that that has multiple benefits, but also differential benefits. And we have to always be conscious of when we're thinking about housing in neighborhood, what are the intended and unintended consequences? We have to acknowledge that housing has benefits to individuals and society. So when we think about what's the cost of this, how is this going to play out, it's really important, I think, to acknowledge that we are paying for the affordable housing gap right now. Are there ways in which we can think about shifting those dollars that we're paying downstream and more upstream solution, like investing in affordable housing? I think that housing and neighborhood are linked, and so we can't think of them in isolation any longer. It's not just about your four walls, it's where it's located, it's who lives there, it's how the neighborhood is perceived. And so when we think about place, we also have to think about people. They're interlinked, and that we have to think about housing as the first in a series against the social determinants. I think oftentimes we think of it as a factorial problem, and therefore we can't just do a single faceted solution. We have to address all different areas. And that really, when we think about housing as the platform or the foundation for opportunity, that opportunity has to be equitable. And there are ways in which you have to have broad partnerships in order to do that to be essential. I think Weinland Park is a great example. The South Side of Chicago, Healthy Neighborhoods, Healthy Families is another. And this is really the wave of the future, is you all, when you are doing your housing and public health and architecture, thinking in these new ways, having broad partnerships is going to be what's going to make us be a healthier community now and in the future. So I just want to thank you so much for your attention, and I'd love to take some questions.
What questions do you have? Go ahead, Sandel.
So you probably know that Columbus has a really high infertility rate compared to the national average. And I'm curious if you've ever done any research, or if you know of any research that links housing instability with higher rates of mortality.
All right, I did anticipate a couple questions. So So it's interesting. We got really interested in. Sorry. So we did. We have been really interested in this idea of timing and duration of homelessness as it influences both birth outcomes and child outcomes. And so this is from a brief that's at the National Housing Conference website. We just released it in June, which was looking at this idea of timing and duration and how kind of the compounding effects of both prenatal and postnatal homelessness matter to housing. And I bring it up just because I think that from what I've heard of the infant mortality initiatives here, they acknowledge the social and economic conditions. That's the first of the 8 points that they're trying to address. I kind of wish they named housing a little bit more explicitly, but I think that what's interesting is this research is really interesting for us to just talk about the prenatal period and how important that is for biologic setting. So just to kind of walk through, this is the families that we follow that have some type of prenatal homelessness only. So they'll report that sometime during the prenatal period they experienced homelessness. These are some that are reporting only being postnatal homelessness. And then these are that are reporting being homeless in both time periods. So it's not shocking necessarily to find out that the people that are prenatal and postnatal homeless, they have almost 100% increased risk of having fair or poor health, or a 59% increase in developmental risk or child hospitalization relative to a family that's reporting never being homeless during that time period. But what's really interesting is we were kind of surprised to see that even after controlling for birth outcomes, right, low birth weight or prematurity, you see this persistent effect of postnatal homelessness where 41% are still talking about being in fair or poor health, 28% are at developmental risk, and 23% more actually are likely to be hospitalized in their young life. And so that when we think about that, there really is these critical windows of development, and the prenatal period becomes really crucial to it. We also just postnatally, when we talked about duration, we also showed that if you were homeless longer than 6 months, you actually had much higher rates of fair or poor health if you were an infant, so a kid under 1 year of age, higher developmental risk, higher rates of child hospitalizations. And so the reason I bring it up is this idea of that if you want to address infant mortality, you can't start after the child's born. You really need to start prenatally. And then what's interesting is in the brief, we actually go over a program that started in Boston called Healthy Start in Housing. And it's where the Boston Public Health Commission and the Boston Housing Authority partnered together to identify housing insecure pregnant women. So they haven't slipped into homelessness yet, but they're close. And they intervened in them to avoid the very kind of prenatal homelessness that we talked about. And they intervened to actually fast track them into a public housing unit. And they actually showed decreases in low birth weight and decreases in infant mortality. And so I think that it's really important when we start thinking about housing, we don't think about it just as homelessness. We think about it as housing insecurity during pregnancy. And more, we've been championing different social vital signs that you could imagine asking, where in a prenatal period, if you ask someone, so have you moved 2 or more times in the past year? Are you overcrowded? Are you behind on your rent? And if you could swoop in and intervene in the prenatal period, you may be able to actually change some of that biologic presetting that's going on. Yeah.
You had mentioned when you're collecting data from like the emergency room, how do you from that data to a certain area? Do you use like census tracts or anything like that to sort of like that sort of cause or why they're in the emergency room to a specific area?
Yeah, I think it's a really good question. So we typically collect data in a cross-sectional way. By that, I mean, we interview someone at the time. We may ask them in like the past year, have you been food insecure? Or in the past year, have you been behind on the rent? And then we do associations with their health status at that time and then report those associations. So it's sometimes hard for us to be sure that we're causally related, right? Because we're describing it at a point in time. One area that we've been really interested in is because we're collecting data in healthcare settings, we typically often families will stay within the area, continue to get healthcare at those sites. And so though it's very expensive to follow people into the future, one way that we have started to think about it is, could we look at the electronic health records? Because many times health records are now electronic. Could we look at the electronic health records at certain sites and then track people from the point of interview forward, seeing if they end up coming back to the hospital, seeing if they end up with a problem like asthma or a problem with developmental delay, see if their weight changes. Do they remain a healthy weight, either underweight or overweight, or do they remain a healthy weight? And so we've started to get really interested in this idea of, can we integrate neighborhood factors into it so that we'll know from the electronic health record whether someone's address has changed. We'll know what their address at the point of interview and moving forward. And so we actually are part of an NIH consortium where they're going to put neighborhood factors together based on GIS coding. So what's the healthy environment for food? What's the pollution environment? What's the crime environment? And be able to bring that in with our data as we kind of track people going forward. And I think that more and more we are not going to talk about housing and neighborhood as separate concepts. I think we're going to talk about them as unified concepts. I think it's going to take some time. The housing research world has a little bit better metrics than the neighborhood level world. It's sometimes harder to come up with what is a healthy neighborhood because everybody wants to do the kitchen sink, right? And so sometimes more and more, I think we're going to end up coming up with these. And I love the opportunity index a little bit for this, but I think that more and more we're going to end up coming up with what's a complete neighborhood looks like, how does that predict health, and can we move forward with it? We're really interested in trying to move our data in that direction. Our data isn't quite there enough yet. So it is really interesting around, again, we tend to report these different types of hardships, whether it be food insecurity or housing insecurity or energy insecurity, right? We have a lot of data around if you're get a shut-off notice from the utility company and how that is meaningful to potentially different trade-offs that you're having to make, like heating your house or paying rent or eating. And so I think you're right to kind of question kind of what's marker and what's mechanism, right? So the example that I'll sometimes give around marker and mechanism is people who use sunscreen are more likely to get skin cancer, right? So on the one hand, you're kind of questioning that. Wait a minute, you're using sunscreen, you're more likely to get skin cancer. Why would that be? Because you're in the sun more, right? So the sunscreen is a marker for the thing that is actually the mechanism for the outcome, right? Now some people will say there are chemicals in sunscreen and it could be that the sunscreen is actually causing the problem. I don't want to go there, but I think, but I do think that we always have to question what's marker and what's mechanism. There is a lot of data these days around what are called the adverse childhood events. Anyone heard that? ACEs? Hands? All right, some. So this idea that particularly children have adverse childhood events, right? Like homelessness or evictions or abuse or neglect. And that carries into your adult health, right? So, and the really interesting part of that, this data is generated from Kaiser in California, in San Diego, in a middle class population. So when we think adverse childhood events, oftentimes we'll think poor families, but this was in a middle to upper income families that they actually showed that the adults that had the number, if you counted the number of adverse childhood experiences that they had, it was like a dose response curve to whether or not you had diabetes or heart disease or other things. And so when you describe, like, is this not more about just whether a parent is neglecting a child versus housing insecurity, I'm going to argue that it's hard for me to separate out which is the marker, which is the mechanism, because I think they can be very tightly linked. And so I think that in many ways, I'm going to still argue that having a stable, decent, affordable home at least provides you the platform to be successful. If you're worrying so much about where your next meal is coming from or where you're going to sleep that night or whether the heat is going to be on, it is really hard to be a good parent. And I think that oftentimes we really need to kind of find ways in which to take those hardships off the table. You're still going to have to do good parenting. You're still going to have to have good education or other types of things, or have good jobs available. But I really will argue that unless you address those first things, I think you're still going to have a hard time. Yeah.
Has your research shown any differences of certain populations being benefited more by housing policy than others?
You know, it's a good question around, I do think there is differential benefit when you start thinking about different populations and what their needs are. And so what I will say is that when we think about housing, it's not a one-size-fits-all solution. There's not one type of housing or one type of solution. I tend to think about it really across a spectrum. So there's really good evidence around people who are chronically homeless that typically have multiple morbidities that they're facing. They may have substance abuse issues or mental health issues. And so there's really good evidence that if you provide them what's called supportive housing, so it's housing with intensive case management, that they do so much better, and they actually typically save money. But it is important to target the right population with that. If you or I were to get supportive housing, we probably wouldn't pay off, right? We're not that sick. You have to subset a certain group of the population that's extremely costly. Some of the best work of describing this is so 2 New Yorker articles. One is called $1 Million Maury, which is by Malcolm Gladwell, and the other one profiles the Camden Coalition and Dr. Jeffrey Brenner by Atul Gawande. And this idea that there was somebody in Camden, New Jersey, that cost the state $1 million. We are not joking, $1 million. And the reason it happened is that he'd go to one ER, and they'd be like, Maury, how you doing? And then he'd have like a diabetic ulcer, and they'd admit him for a couple of days, and then he'd leave, and then he'd go to a different hospital, and they'd be like, Maury, how are you? And they would then readmit him for his diabetic ulcer, and then he would go somewhere else, and nobody had the real picture, right? Because he was going to so many different hospitals, and yet he racked up $1 million in Medicaid bills over that year. And so, yeah, buying him an apartment with a case manager is cheap, right, in relative to that. And so when you think about it, those are one area where I think that we can, figure out ways in which to align those investments. I think the hardest part in some ways when you think about a return on investment on housing is, I'm a pediatrician. I want you to invest in young kids. They'll pay off, but they'll pay off in 20 years when they graduate on time from high school. And most politicians don't have an attention span for that long. And so it's trying to convince people that it's still worth it to invest sometimes in certain populations at different critical windows. And I think that I truly believe that we all benefit from affordable housing investment, but it is really about strategic communications to make that case, because if the expectation is that it's going to save money instantaneously, that may be a hard bill to necessarily hit, but I definitely think that there are benefits. And so when we think about housing, it really should be targeted. The level of the intervention should be targeted, and we shouldn't think about it as just one solution, but a multifactorial solution.
What other questions are there?
This is clearly, the solution to this is clearly multi-pronged. But as a healthcare provider yourself, what do, and as someone who does work with medical legal partnerships, what do you see as ways that providers of healthcare, people who interact one-on-one with people who are suffering from housing challenges?
Yeah, so it's really interesting. I think that in a lot of ways, housing insecurity as a concept is something that is sometimes hard to talk about. I will often say that housing insecurity is not an eyeball diagnosis, right? I can't look at someone necessarily and know that they're housing insecure. And in some ways, I think people often, again, will think about homelessness as the problem, but I say that that's really the part of the iceberg you can see, right? That's what's in front of you is that problem. But there's a lot of iceberg below the surface. And so I think that more and more to engage healthcare, we need to understand the scope of the problem. And so we actually have talked about in Children's Health Watch, we validated a 2-question screener, which we call the hunger vital sign, about 5 years ago. And it's really 2 simple questions. In the past year, have you been worried your food would run out before you could buy more, or has your food run out before you buy more? If you say yes to either of those questions, you are food insecure. We did a really nice statistical analysis against kind of the gold standard 18 questions. And so the hunger vital sign is now being adopted by healthcare institutions, right? Oregon is making it a performance metric for its Medicaid providers. It's saying you need to screen the hunger vital sign at a certain percentage or we're not going to reimburse you for care. And so that I more and more want to see us develop a housing vital sign, right? Are you moving 2 or more times in a year? Are you overcrowded? Are you behind on rent? Are you homeless, right? Like simple questions that you could integrate into healthcare, because the reality is if they ask it in certain environments, 40% of the people are going to say yes. And when a healthcare institution sees that, it's going to think, oh my God, I need to be doing something about housing. I will say housing is a, so there is this now new buzzword, and not so new, but social determinants of health. And this idea of really naming housing as a social determinant of health is really a mantra of mine. I think it tends to not be named enough. It tends to be kind of built environment or other things. They don't bring it up to talking about it more directly. And I think that what's important is that part of what healthcare institutions are required to do, because many of them are nonprofits, is they're absolutely required to show that they're doing community benefit. They file with the IRS that they have done a certain amount of community benefit, that they've seen what their community health needs are. And what's interesting is that you're starting to see, like the American Hospital Association and the Catholic Hospital Association, petition the IRS to change how housing is considered on that community benefit. So that means they're thinking about this. They want it to be seen in a certain light. They know it's a community health need and they want to think about it more. And so that more and more, I really want to try and incentivize healthcare to ask about housing and then to start thinking about it, not just on the patient level, but on the population level, on the public health or the community level. And this is where healthcare is going to need partners to do that, because they won't know how to do it. And so you guys are the right audience to necessarily talk to them.